Welcome back, guys, to another episode of Hormones Happen. I'm your host, Jeremiah, and I've got a special guest with us today. She's a nurse practitioner with a background in rheumatology. She's HRT certified through World Link Medical, and she's the owner of Vitality Med Pro. Jennifer, thanks for being with us today.
Thanks for having me. It's great to be here.
Yeah, so Jennifer, before we get into it too much, tell us a little bit about where your clinic's at, who you treat, and how people can get a hold of you.
So I am in Northwest Arkansas. I'm right on the border of, I could literally throw a rock and hit Oklahoma. So like 5-minute drive and you're in Oklahoma from where my clinic's at. So most of my patients are Arkansas and Oklahoma. I'm not licensed in the other states. We do mostly hormone replacement, some peptide longevity medicine, and then I'm also doing functional medicine. But really, all of my patients get functional medicine, whether they ask for it or not. That's just kind of how I approach everybody.
What got you into integrative medicine?
So it's always been, I think everybody in healthcare kind of always sees how we could have prevented this, right? When you're seeing that patient who's got, a comorbidity list, 10 pages long, medicine list. And so, but it was really rheumatology. I kind of saw the writing on the wall. It's like, we're just going to cycle these patients through every biologic that is available until the end of time. And no one's going to get better. No one's going to be healed, so to speak. And we're just going to throw medicines at them forever. And so that to me was very disheartening to think that I'm never truly going to fix anybody. So that's kind of what got me into functional medicine, because I was at that point listening to people like Mark Hyman and Institute of Functional Medicine and how he was able to. And then I started following an integrative rheumatologist. And it was just, you get all these signs from the universe to start doing these things. And when you're ready, you jump. And so I went to School of Applied Functional Medicine and haven't looked back.
Amazing. Amazing. So I guess a great question that I like to ask everyone is, what do you think some of the biggest barriers to care are for someone who wants to take a functional approach to medicine?
Well, you're going to get a lot of kickback from your allopathic providers. When we start talking about testing gut biomes and things like that, they're just not up to speed on where this stuff really is. And I think that there's a lot of different types of people in the functional medicine space. You do have your hacks and, people who are not necessarily trained allopathically. And, so there's all kinds of providers in this space. But unfortunately, some of them are legit and some of them are not. I like to keep a foot in both worlds. I want to do everything I do must be evidence-based. So I'm not, I can back it up, with studies. Whatever I tell a patient to do, there's going to be a study to back me up on it. But that's really what I think, that regular medicine is not up to speed on what we're really doing over here, because of stuff like TikTok and, like the kooks and the, in that space. There's a lot of charlatans in this space. There really are.
Yeah. I've been called a kook once or twice with some of the things I say, but yeah. And that's one of the things that really drew me to you is I watch your TikTok, and every TikTok you're talking about the literature behind it, the science behind it, which I can definitely tell you went through World Link Medical, because Neil Rousier is always talking about the science and the literature. Exactly. Which is huge, right? It's a guiding principle for us as far as like what is safe, what can we do, what's going to help, what's going to hurt. Mm-hmm. And so one thing you talked about that I find very interesting, because I've seen it time and time again, is the effect of all these endocrine disruptors on the younger population. So what are your thoughts on that?
It breaks my heart. I had a patient today, 22 years old, testosterone level of 300. And he has not had any kids yet. So, and he's in this spot where we checked his triglyceride to HDL ratio. It was like 7.9. So we know this kid is insulin resistant. And so he's in this hamster wheel now, right? Where he has low testosterone, he has insulin resistance, and he can't really get out of it. Something has to give here. And so I'm going to put him on testosterone. I'm going to give him something to preserve his fertility in hopes that we can start to reverse one of these dynamics for him. But my concern, I have sons, so this is my concern too, because we know now endocrine disruptors can cross the placenta. So even in vivo, they're not getting adequate androgen exposure. And so out of the womb, they're born with low T. And, if you look back in the 80s and 90s, the normal range was this. And even since I've been doing this, I've watched Quest Lab change what they consider normal ranges. It just goes click, click, click down every 2 or 3 years. And it's sad, but it's all endocrine disruptors. It's our diet. It's our environment. And how can you fix that? I mean, how can you really fix that? So
right.
It's a tough spot to be in. But I try, to give them, eliminate the plastics as much as you can. I give them a list. These are like the known endocrine disruptors. Start reading labels, guys. Ditch your plastic water bottles, your plastic meal prep containers. Go to all those things. And the girls hate it when I tell them, the fragrances, guys. I know we love the way that Febreze smells, but it's jacking your hormones. The
Right.
fluoride in your water is jacking your hormones. I'm saying get a filter for your water. I mean, it's just a million little things. I call it death from a thousand paper cuts because that's really what it is. Just every little thing in your life is like jacking your hormones.
Love that saying. I actually switched to a fluoride-free toothpaste a while back, and I haven't
Yeah.
looked back. I love it. I mean, kind of had to get used to the fact that it doesn't have as much foam to it, but
Right.
hey, I'm going to eliminate fluoride as much as I can. And
Right.
I did it because I wanted more nitric oxide. I wanted better pumps at the gym.
Exactly.
What's wrong with that?
Nothing.
Yeah, nothing. And so it is sad because I see the same thing as you. These young men, they come in and their testosterone's on the ground floor. These men will never have a peak. They're never going to be able to experience that peak, not to mention fertility is negatively impacted big time because of this. Now, I actually have some patients, fathers and sons, and typically when I check them together, the father's is always higher than the son's testosterone. It is just
Yeah.
mind-boggling.
Right.
Yeah, I mean, there's no way to explain it other than sad because you're very right. What can you do about it? Can you go live off grid?
Hmm.
No. I mean, this is the cost of comfort for this first world developed country that we live in. And so we're very fortunate that we actually have something that can help to mitigate those issues, hence hormone replacement therapy.
Right.
Kind of along that same vein of testosterone replacement therapy for men, what are your thoughts on Clomid versus testosterone as monotherapy?
Their labs will look amazing, but they're probably not going to feel great. So I will use it. I'll use it in conjunction with testosterone, but it's something that I'm always kind of like, if you don't feel good, let me know because men need estrogen too, right? I mean, it's one of the things we know is beneficial in a lot of things. And so I don't ever want to take that away from them. But at the same time, if they're 22, I have to worry about their fertility. But I won't ever use it as monotherapy unless we're just doing straight fertility protocol. And that's about the only time I use it as monotherapy.
Yeah, I've never seen great results with it. I've never seen great results with Clomid in general. I do feel like a lot of men that get on it end up having some kind of irregularities. The only thing I can hypothesize about that is just because there are two different isomers in it, zuclomiphene and enclomiphene, and they kind of do different things regarding the estrogen receptor and they have different half-lives. So they're kind of competing with each other, and then one lasts longer than the other. So I've seen, I guess I would say, better effects with enclomiphene, but still not great effects whatsoever. What are your thoughts with HCG as monotherapy?
That's my
do you
gold
think?
standard go-to. So
Is it?
yeah. I mean, I should say I don't even use Clomid. I only use enclomiphene. If I'm going to use, SERM, but HCG is going to be my, I know it's pricier and I know it's a shot and they're having to take it 3 times a week or whatever, but it's just, I mean, for intratesticular production, it's better overall. It won't raise your testosterone levels quite as significantly, but it depends on what we're going for, right? Are we going for fertility? Are they on it with testosterone? And it's always meet the patient where they're at. What are they comfortable with? So I use it a lot. I use a lot of HCG.
Cool. That's awesome. I have a lot of guys on TRT that use it in conjunction, not necessarily just for fertility, but they feel better, right? They like the testicular fullness, right? They like the way that it makes you feel. And, it makes sense because as long as your testes are functioning appropriately, you're going to release testosterone through a more natural pathway. And that's going to result in a lot of these other metabolites, HEA, androstenedione, that you don't get just with testosterone. And I think that's one of the reasons why there's kind of a honeymoon phase when you start TRT, because there's a period where your natural testosterone and your exogenous kind of meet here at the middle, and then your exogenous comes up, your endogenous falls. And so I think that kind of HCG bridges that gap. But as far as monotherapy, I've seen guys do okay on that too. I think that there's 1,000 different ways to do this. I think that we get too stuck on my way's the right way.
Yeah.
You really miss a lot of people because guess what? These patients don't read the studies, right? Everyone's different,
Yeah. When you learn better, you do better, right? Because when I first started, I was definitely giving out estrogen blockers like candy. But then, you learn like, crap, that's not good. So, I mean, you just evolve. There's always going to be new science. There's always going to be new, things to prove, shake your paradigm. And so if you're not out there like staying current on this stuff, then you're going to get left behind.
And it changes all the time. Changes all the time.
Yep.
Now, I guess this is something that's always kind of been on the forefront of everyone's mind. You have a guy, you're talking about, hey, I think you would benefit from testosterone. And then he pops the question of, I heard this causes prostate cancer. What's that conversation sound like?
We're going to beat this. No. So I was reading a study just last week. they were actually giving men with active prostate cancer testosterone, and they did not see a progression of disease. So that even that paradigm is starting to be questioned. Is it truly bad? Does it truly feed prostate cancer? So I think that's where this is headed. But no, we're not going to beat that dead. It should be put to bed. It's an old myth that won't die with this stuff. Give them, your PSA is going to jump a little bit. It should level out. We'll keep an eye on it just in case, but it does not cause prostate cancer. Because think about, when do men get prostate cancer? What time of life are they getting prostate cancer? When their androgens are declining. And same with women and breast cancer, right? That's when we start seeing breast cancers, when their estrogen levels decline. So it's kind of like blaming the fire on the fireman who's at the scene of the crime. There was a study that came out, I kind of talked about that. Every man was over 65. There were over 5,000 men studied. They actually had a decreased risk of prostate cancer in that group. But the ones who used a prostate plus an estrogen blocker did not see a decreased risk of breast cancer. So that's, so just more and more studies all the time about benefits of testosterone, and we're not scared of prostate cancer anymore.
No, put it to rest, guys. Put it to rest. And the reality is we don't know everything, right? We think we know a lot more about the human body than we do. We really don't.
Right.
I actually did have a urologist on, and he talked about how even patients who have prostate cancer, he will put them on TRT. What's the difference between a male that has prostate cancer with a natural level of 700 and a male that has an exogenous level of 700 because of TRT? Yeah. There isn't a difference. And in fact, men who develop prostate cancers with lower levels of testosterone are more likely to develop high-grade lesions, right? This is a higher Gleason score. This is a more significant risk. And so testosterone isn't the enemy that we used to think it was. They used to say it's like putting gasoline on a fire, right? And that's just from poor literature back in the 1940s. But we do a really good job of holding on to these studies and just saying that's the way it's always been done.
I've read a statistic one time that, whenever something changes in medicine, it's going to take on average about 10 years for that information to filter down to your primary care. And so that's where a lot of these people are getting their information from, their regular doctor. You have a strong family history of prostate cancer, you can't do testosterone. So, I mean, unfortunately, that's just the way it is.
And it's the same thing with women with breast cancer. So let's kind of transition over to there, right? As far as women and the breast cancer risk, what's the truth on this? Does it cause breast cancer?
No. So, I mean, the North American Menopause Society, and I feel like they're a little bit behind too. Cause because I'm, from World Lake Medical, trained, but I feel like they're finally kind of starting to catch up to where like Neil has been for a long time. But overwhelmingly, there is not an increased risk of estrogen only hormone replacement. There is a small, insignificant risk with progesterone, even bioidentical, but it's still, we say that the benefits far outweigh the risk. So the prevalence still about 2% is about what you're looking at of breast cancer. A4M, I don't know if you're familiar with A4M, Advanced Academy of Anti-Aging, so I like to go to their conferences too. There was one doctor presenting, Dr. Glazier, she was about to publish her results, but she had put progesterone, she was treating breast cancer with testosterone pellets that were placed in the breast and shrunk the tumor. And she was also using high doses of progesterone. And so she probably has published at this point. But so yeah, that was really, really cool. It kind of turns your thinking upside down on this stuff.
Wow, it really does.
Yeah.
It's amazing, right? When you actually dive into the actual studies, there's so much, and there's so much we don't know, right? Mm-hmm. Because for those of you at home, right, there are 4 different types of estrogen in the human body, right?
Right.
Estradiol, that's the hormone of youth, and that's a very protective type of estrogen. Right. I've talked to some, naturopathic doctors that talk about how because it actually activates estrogen
yes.
beta receptors, it's the brakes on growth, right?
Exactly.
You go through menopause, now we're looking at estrione. This is estrogen alpha. These are growth promoting receptors.
Exactly.
And so think about it. Women are most likely diagnosed with breast cancer after menopause for a reason. And so that estradiol is so protective. Now, I know you talked about it on your TikTok and I love it, but will you tell us just a little bit about the faults with the Women's Health Initiative study?
Gosh, yeah. So this came out in the early 2000s. Whenever they did the study, they put everyone in the study was already 65 and over, right? So they'd already been out of menopause for like 10 plus years. What they found was increased risk of cardiovascular disease, stroke, MI, things like that. So, but this is the age where that's prevalent anyway. But what they saw was that the arm that had synthetic progesterone plus synthetic estrogen saw a slight increased risk of breast cancer. So they halted the study. What they did not publish, which should have been published, was that the estrogen only arm actually saw a decreased risk of breast cancer. And again, this was synthetic estrogen. It wasn't even bioidentical. But even synthetic estrogens saw lower risk of breast cancer. And all this should also be noted that the all-cause mortality, if they did have breast cancer, was lower when they were on hormone replacement therapy, even synthetic. So yes, they got breast cancer, but it did not kill them. And so it was not, anyway, it was just, when bad news travels faster than good news every time. And doctors have been scared to death of it since then. And they're not trying to hear the new science on it. They're just stuck in that 20 years ago study.
Yeah, that was a real travesty for women. And if I'm not mistaken, I think the actual purpose of the study was to show the benefits on cardiac
Yeah. Yeah.
of hormones. But the reality is when they portray the findings of the study, there's always going to be a little bit of bias, and of course, mixing absolute risk with relative risk, and then portraying this horrible number to the population
Mhm.
is going to cause a significant issue. And like you said, these were synthetic hormones. This was a conjugated equine estrogen.
Right.
Estrogen's from a horse, guys. This is not
Oh, yeah.
bioidentical. And it was medroxyprogesterone acetate, which they still use today in birth control, but
Sure.
that's a progestin. That's
Yeah.
not a progesterone. So it's not relatable in any way, shape, or form to bioidentical hormone replacement therapy.
And when we talk about the significance of the numbers, it was like, 1 in 1,000 get breast cancer, but on this study, it was in 4 in 1,000. So that sounds like, when you put it in those numbers, it's not that big of a deal, but it's a 40% increase, right? So when you say 40% increase, you're
Yeah,
like, oh, shit. But no, it went from 1
exactly.
to 4 people. So it wasn't nearly
Yeah,
as serious
exactly.
as all that.
The the way they lay it out, there's
Yeah.
always some type of an agenda, and that's the problem with hormone replacement therapy. Is there's just not a lot of high quality literature to show the benefits of the bioidentical hormones that we do, because who's going to fund these studies? The
Right.
pharmaceutical companies surely aren't going to put a cent into prevention. And so as far as hormone replacement therapy for women, what are your go-tos as far as estradiol, testosterone, progesterone?
Yeah. I love the patch. For women, I love the patch. It's going to be covered by their insurance and they appreciate that. And it's, we start them on a load. I mean, you always have to do progesterone. I usually start progesterone first, right? Because we know if they're 42, they need progesterone. Maybe they need estrogen, maybe they don't, but eventually they're going to need estrogen. So then at that point, we just go in with a low dose patch and titrate it until their symptoms are better. But yeah, the zero clot risk with the patches and the fact that it's easy, you don't have to, it's not a pill. We don't have to worry about that estrone conversion via hepatic first pass liver metabolism. So it's my go-to. I also love estrogen injections. So whenever you kind
Okay.
of hit that wall and you can't get their levels higher with the patch, you've maxed it out and they're still struggling to get their levels in the 50s. At that point, we're going to move over to the shot and we can titrate it as high as we need to go to get their levels where we need them. So I will use the pill. It's my third down the line, though. It's not my first.
Yeah, sure. Yeah. And that's really what it is. That's a great example of, what, we individualize it to you, right? It's not your first. You have like, hey, my first, second, third, but
Right.
the patient may just benefit from third option. That's them specifically. Now, what are your thoughts as far as testosterone for women? Do you think there's a place for it?
To me, yeah, I love it. I love it for everybody. But I think the gold standard is always going to be injections. I mean, I just feel like you can titrate the dose easily. We know you're going to absorb 100% of it. You're way more likely to be compliant with it versus a cream daily. I'm not a fan of pellets. I know Rozier likes it, but I feel like I fix so many pellet problems every week in my clinic where, a woman comes in with her testosterone levels are 1700. Like, holy crap, guys, we can't do this. I like the shots. They're my favorite. If a patient's willing, I really push them to do the shots because we can do sub Q, right? I mean, because we're taking like this much on sub Q and it works really really well. We're not having to take the big doses that men are, so we can get away with using an insulin needle. So they're way more likely to stick with that than a intramuscular shot.
Yeah, it's super simple. Same as peptides,
Right.
GLP-1s, any of that, guys. This is sub Q makes a huge difference. If
Hmm.
I had to use a big needle for my TRT, I would have never got on it. I'm so afraid of needles, but that tiny little insulin needle, I'm
Yeah.
not scared of that guy.
Yeah.
So kind of along the hormone pathway here, you made a specific TikTok that I thought was absolutely fascinating about the lack of progesterone and postpartum depression.
Yeah.
Yeah, can you elaborate a little bit on that?
So, I mean, that's one of the things I'm always screening my patients for. Like when I have a female in here, did you have postpartum depression? Because you can kind of tell the woman who's had to have, an ablation because she's had these heavy periods. But you can always, and even my PMDD, I'll see teenagers who have, PMDD. It's progesterone, guys. They need progesterone because we are starting to see part of that whole endocrine disruptor phenomenon that we're seeing is progesterone receptor site resistance. That's a big problem with PCOS. is they have the progesterone, but they're not able to necessarily, the receptors aren't necessarily able to bind. So I give them exogenous progesterone, and I would say 9 times out of 10 it helps. So, and then you have progesterone intolerance, which is a whole other ball of wax yarn that we won't really necessarily get into right now. But for postpartum depression, I think that before we start throwing SSRIs at them, we should at least try hormones, because it's easy, it's cheap, and it's something that their body should be making, but sometimes it doesn't rebound if they're okay, because it can kill your milk supply. So that's something that we have to have the conversation about too, if they're breastfeeding. But ultimately, we want her mental health so that she has no thoughts of harm of herself and her baby. Breastfeeding is going to be like lower totem pole priority.
Do you prefer oral micronized?
Absolutely. You got to get that allopregnanolone metabolite,
You
right?
got to get it.
Yeah,
The
you got to get
Valium of
that
the
GABA
brain, baby.
receptor stimulation. That's what's going to chill them out.
Yeah. And, you made a great point about the fact that, these endocrine disruptors don't just affect our testosterone. Sure, we talk about that all the time, but all of our hormones are being affected by this. It's crazy to think that just one hormone's being singled out by all these
Right.
endocrine disruptors, right? I was talking to another practitioner who was doing some research on progesterone for men.
Yes.
I've been taking progesterone
Yes.
for a long time. I don't take it every single day because I don't need to protect my uterine lining. I don't have a uterus,
Right.
but I take it pretty often. It's so amazing to help with sleep. It's the best sleep you'll ever get.
Yep.
It does feel like a Valium, and men benefit significantly from it.
Absolutely. Because I mean, you think about how many of your patients probably played football when they were kids, right? How many of them probably took a good hit to the head while they were playing football? So we already know they're going to have lower pregnenolone levels if they had a significant brain injury, and that's going to affect their progesterone too. So sometimes you can just give them pregnenolone, and that's going to help. But I mean, if it's not hitting that cascade, that hormone cascade down to progesterone, then there's a place for progesterone for men.
Absolutely. I mean, we're the script's kind of being flipped, this whole hormone replacement therapy, right? There was a time where they said for women, it's just estradiol. Then it's like, whoa, estradiol and progesterone. Don't give them testosterone. Now it's
Right.
like, oh, geez, give them testosterone too. But for us guys, why can't we say, well, yeah, we love testosterone, but we could benefit from some progesterone. And you know what? There's clinics out there. I've talked to several physicians that even do supplemental estradiol.
Yeah.
And I've taken a milligram of estradiol for about a year. Okay,
Yeah.
guys, guess what? It doesn't cause any harm. I don't have gynecomastia, no nipple
Right.
sensitivity. The myth is busted, guys, And so the reality is when we talk optimization, right? We're not saying replacement, we're saying optimization.
Mm-hmm.
We're talking about putting yourself into a better state of health overall. Right. I mean, not everyone's going to need that many hormones, right? But the reality is you individualize that to a specific patient.
Sure. Absolutely. Because I mean, you have your diabetic patient. Well, you're fighting estrogen on them because they like to aromatize a lot because of the insulin resistance. But you're right. I listened to the University of Michigan head of urology talk about this, and he's like, he likes to keep his patients' estradiol in that 70 to 100 range. So on a Reddit forum, that would make their heads explode.
Oh God, yeah. Right. Oh my God. I know. It's all relative, guys. The
Yeah.
ratio, testosterone to estradiol
Right.
ratio. My personal estradiol has been as high as 120, but when your testosterone's anywhere between 1100 and 1500,
Exactly.
it's fine. Relax.
Yeah.
Yeah, if it was 500, yeah, I'd have a real problem. But the reality is it's all individual based. And I do see some guys that just aromatize at higher rates for whatever reason it may be, whether it's just excessive adipose tissue, just
Mhm.
aromatization, genetic defects,
Yeah.
other substance use. There's so many things that can affect it. But the reality is I don't like to say that there's no place for aromatase inhibitors. I think there are some use cases here and there, but it is very rare because one of the last things we want to do is deplete that estradiol.
Agreed. And like I said, it's hard when they have like the diabetes. That's one case where you're just like, well, I can't
Right.
really reverse your diabetes necessarily, but 9 times out of 10, it's going to be something in their lifestyle that you can tweak, or some other hormone imbalance that's related to lifestyle that you can, help them with. But yeah, I agree with you on that. Never say
So
never on any of this stuff.
yeah, I love that. I love that because as soon as you think you know everything, you're going to get
Mhm.
humbled very quickly. Now, when you're starting that hormone replacement therapy on a woman who's postmenopausal, how does that conversation go when you're talking about breakthrough bleeding?
So I tell them some of this can like convert. Women can aromatize also to estrogen. So we're going to have to be checking if she's having breakthrough bleeding. First of all this is normal in the first 6 months of starting hormones or adjusting hormone doses or any of that stuff. So I mean, And even the Menopause Society doesn't necessarily recommend routine ultrasounds, uterine lining ultrasounds, because we don't know, what your baseline is necessarily. So to go in and check it after you start hormone replacement therapy, we can't tell if that's worse or better or whatever if we don't have a
Right.
baseline. But if you are having, if we can't, if we're checking labs and they're still having the spotting, we're going to get an ultrasound. We're going to rule out the scary things, right? And then, but after that, it's just we got to tweak your doses. So it's common. I mean, it's not that common, but it happens. I definitely deal with it. Maybe once every 2 or 3 months. A patient who's having spotting, and we can't get it to stop with even with higher doses of progesterone. It just keeps happening. So it's it's one of the things about it. You just can't really necessarily avoid it in everybody.
Absolutely. There's going to be a degree of experimentation with
Hmm.
everyone, right? That's just the way it goes because everyone's different. Everyone responds differently. Some people don't have a single issue in the world. It can be a more perfect
Right.
transition. And some people are going to hit every single roadblock.
Yep.
Now, would I say that person that's hitting all those roadblocks, sorry, you're not a candidate. Absolutely not.
Right.
It just means we need to tailor this to you. We need to work with you to get this going because the reality is we could all benefit from this to some degree.
I agree. I'm thinking of one patient in particular. She's elderly. She's like in her 70s. I've got her on the lowest dose patch, 0.025, and it's a twice weekly patch. I have to have her leave that patch on all week or she will start spotting. And she's on 200, 300 milligrams of progesterone, but that's how sensitive she is to it. So she's not the normal, but I mean, it's not, this is what you're going to run into when you start doing this stuff. And there's,
Absolutely.
can't get the dose lower. There's not a way to get a lower dose of estrogen. So
Right. You could just have her look at the patch.
yeah, and she's going to, endometrial thickening,
Another question I have as far as your male patients go, what kind of things do you prefer as far as with HCG, testosterone? Do you prefer like weekly injections, twice weekly injections? What are your thoughts on any of that?
Yeah, I know if you listen to Dave Lee, you know who that is. Yeah, so he's all like, sub Q 3 times a weekly. Good luck finding someone to be compliant with that over the years, right?
Yep.
So
Yep.
my line in the sand is really twice weekly, guys, is going to give you the best, bang for your buck, get you truly, optimal. But if at the end of the day, it's you're the one taking the shot. So if we have to compromise with once a week, then so be it. But I really do try to push them to do it twice a week. On the HCG, I'm more on the 3 times a week sub Q. It depends on what we're doing it too. If it's only for testicular atrophy, we can get away with twice a week. But if they need that fertility, I'm going to push that 3 times a week.
Right. And I mean, I think that's it. Like, how much are you willing to do? Because when you
Right.
think about it, with the medication, just any kind of hormone, we want as steady as possible daily, right? But who's going to do daily
Right.
injections? I'd say for a couple months, I did every other day. I got so sick of that so quick.
Yep.
And then you just start thinking like, well, this isn't even worth it anymore.
Right.
And so I think twice a week seems to be that absolute sweet spot for most.
Yep.
And I've personally seen guys have significant benefit versus once weekly. But hey,
Yeah.
if you're doing once weekly and you feel good, that works.
Yep.
Some people say if you're doing once weekly, why even do it? Come on, it's better than no times weekly.
Right. Yeah. I've tested labs. I want to see what your levels look like if you do it once weekly versus twice weekly. We're looking at 1400 was your level doing it twice weekly. And then by the end, once weekly at the last day before your next shot, he was down to 700. So literally half. I mean, so that's
Mhm.
how big the difference is, how much you're falling if you only do it once a week. This is just one patient, but it's going to be generally
Right.
true. And then you have
Yeah,
to think
of
about
course.
things like how fast do they metabolize it? Because not everybody metabolizes the same. Where you're injecting it, your butt cheek is going to absorb slower than it will on your thighs. So there's some nuances to this stuff.
Of course, different types of esters, different types of oil. I typically use cypionate. We know the half-life is
Okay.
7 days.
Right.
And so, the reality is that's another thing to think of too, right? Because the timing of your blood draw, I'm not
Yeah.
a huge stickler. I don't really care when you get your blood
Yeah.
drawn as long as how do you feel?
Right.
Because, when you're doing it more than once weekly, you're really not going to be getting any kind of
Exactly.
like trough and nadir dosing. It doesn't exist when you're doing it that frequently.
Agree.
So, Jennifer, what is one last thing you'd like to say for that patient out there that's on the fence thinking, okay, I've always wanted to start hormone replacement therapy, but I've always been really hesitant about it. What would you say to him?
I think we have to think about longevity, right? I mean, I really do feel like diet, exercise, and hormones are the fountain of youth. And right now we're looking at, people on average are going to live to about the age of 60 without a chronic disease. And at that point, their quality of life is really going to plummet. So if you're in your 30s, your 40s, and you're starting to deal with these hormone imbalances, now is the time to get proactive about it because it's going to change. We think, it changes your body comp and all that, but it's so much more than that. It changes the decisions you make. Like, do I couch rot or do I get up and go to the gym? That's testosterone, baby. That's the motivation. So in 10 years, you can look like a totally different person just from the choices you make. And that is all coming from your hormones, because your neurotransmitters, your dopamine, your GABA, your serotonin, all modulated by hormones. So yeah, at the end of the day, if you try and you hate it, you can always quit. So, I mean, you don't have to keep taking it forever, but it's worth it. I think that people need to invest in themselves in this regard. And we always think, we want to have good golden years, but that's not given. That has to be earned. So if you want to be out playing with your kids and your grandkids and being active, then you got to do those things. And hormone replacement is a huge part of that.
Absolutely, 100%. And before we leave, can you just tell everyone one more time how to get a hold of you if they want to be a patient?
Yeah, so I am telemed for Arkansas and Oklahoma. My website is Vitality Med Pro. I have on my Facebook Vitality Health and Wellness. We are about to open a new location. We're going to be getting into a lot more longevity stuff. So yeah, you can reach out to me on any of my socials, my website. And those are probably the best ways to get a hold of me. But I'm happy to help take over other regimens, get you optimized. If you're not happy where you're at, be happy to help.
Thanks for joining us today, Jennifer.
Yeah, thanks for having me. It was great.